every day, all day long, is to just be informed and be able to be there to help each other. So we're always grateful for Emory Decatur for showing up. They're our longest serving community partner. And Keisha Wilson has never been here before, but but we're so glad to have her, and we're thankful that she's here with this important program on stroke and the signs and the symptoms and all that. So thank you, Keisha.
Thank you. Hi, good afternoon, everyone. Again, my name is Keisha Wilson. I am a newer stroke coordinator for Emory Decatur and Emory Hillendale Hospital, so I operate out of the DOU. I'm very excited to come here today to talk with you guys. This is my first adult presentation. I usually get to do new nursing students or staff, so it is really nice to get to come out to the community and to be able to talk to everyone here. Because as we know, the stroke usually starts in the community. So getting that education and all that information out to you guys is the most important. Knowing the signs and symptoms, knowing the things that you're looking out for, not only for yourselves, but those that are around you as well. Sometimes it's those others that are able to see that something is wrong or something may be just a little bit different, and you guys will be the ones that will sound the alarm or call the alert, say, hey, something is wrong here. So I just wanted to spend some time to get to talk to you guys today to talk about stroke, talk about those signs and symptoms and things to look out for, the higher risk factors. And then I got you guys some great pamphlets and handouts, some from the CDC, as well as some from A Healthy Diet, which we'll talk a little bit about once we're done. And that information just kind of reiterates the things that I'm going to talk to you guys about today. And we're just going to work through this together. It'll be some time at the end for us to have some conversation, hopefully some great dialogue, ask questions. I love questions. Questions are great. Just so that we can all make sure that we have an understanding of those things that pertain to stroke and your health and how you work into that factor. Okay, guys? All right. All right, so first what we're going to do is we're going to talk about some of the stroke facts. And these are just the stroke facts, and these are current facts here. So with our stroke, up to 80% of strokes are preventable. That's a huge number. Just saying that only 20% of those are ones that are out of our control or things that we didn't have any control over. But 80% of those strokes are preventable. Also, someone in the United States has a stroke about every 40 seconds. So since I started talking maybe 3 or 4 minutes ago, we've had several people in the United States that have had a symptom of a stroke so far. Every year, more than about 795,000 people in the United States total have a stroke. And that is a huge number, which is why it's more and more important to talk to people about those risk factors and things that you guys can look out for. And then knowing that the risk is twice as high for African Americans, and also they have the highest death rate as well when it comes to strokes. The leading cause, stroke is also the leading cause of serious long-term disability. I think we may all know someone or know of someone who may have had a stroke in the past and have some disability that's following behind that. And so it is the leading cause of serious long-term disability. And then just remembering that that risk increases with age, but anyone, absolutely anyone at any age can have a stroke. For our patients here at the DOU, because we are adults only there, I have some patients as young as 19 that will have a stroke. And they can definitely happen younger. I'm sure Children's Hospital can tell us of children that have stroke, that have stroke as well. But I see patients from 19 all the way to their 90s. So strokes can happen to anyone at any age. It is not something that is specific to age alone. So we'll start at the beginning. What is a stroke in the first place? A stroke happens when there is a stop or interruption in the blood flow. That's the most simple way that you can put it, the most simple thought that you can have. We all know that we have those blood vessels in our body that constantly have blood pumping through them. A stroke happens when that blood stops. Now, whether it stops permanently or stops temporarily, it's the difference in the different types of stroke and how that happens. So again, this interruption or stopping that blood flow is caused by a blockage in the vessel or a rupture or a tear in the vessel. And then I wanted to make sure I included some visuals here to kind of make it make more sense. So the different types of strokes. Ischemic is called an occlusion stroke, which could be either one of these here that you see. And what you see here is plaque, that's on the side of those vessel walls. That's that fat that we have in our body, in our vessels, when they're telling you to watch your cholesterol or watch how many fats you eat, or the different kinds of fat, the good fats versus the bad fats. Those are the things that can get stuck to the walls of our vessels. And when they start to pile up, they cause an occlusion, or they make it really hard for blood to be able to flow through. Now, also, we have in ischemic strokes, we just have some blood clots here. And a blood clot is just a coagulation of blood or pooling of blood that has kind of stuck together and become sticky. And again, it makes it really hard to move through those blood vessels. And then when we're talking about the rupturing or the tearing of the blood vessels, as you can see down there, what happens is there's a break in the wall, and then blood gets to be able to flow through, which is not what we want at all. We don't want blood free roaming throughout our body. But that is what happens when we have those things called a hemorrhagic stroke or a bleed. You will hear us call them a bleed as it's short. In addition, we do have TIAs. Those are what we know as mini strokes and are fairly common, and a lot of people usually know of the mini stroke at least. Now, risk factors. We're going to talk about two different kinds of risk factors. We're going to talk about those that are non-modifiable, which means things that I cannot change, or the things that we don't have any control over at all. And when looking at things that we can't change, those are going to be things like our age. Now, while we say that anyone at any age can have a stroke, we do see a higher incidence in adults that are over the age of 45. Gender, which is also something we have no control over. With gender, we usually see younger ages in men having strokes, as well as older ages for women that are more susceptible to strokes. But gender, again, being something that we have no control over at all. Race and ethnicity, again, talking about the African American culture, the Hispanic, as well as the Asian cultures, there are higher incidents of having strokes, which puts them in that risk factor group. But again, yes, absolutely.
Why is it that you have a higher age in race African American? Is it a genetic factor? Or
it's partly genetic, as well as just being more predisposition to having high cholesterol levels or different things. So it's purely genetic. It's not anything that we can control. It's just something that we see more often.
Environment, the food, the diet they eat.
Well, for African American cultures, it's more so tied to food and diet. With our Asian cultures, they usually have, I hate to say, a more healthier diet, but they have diets that contain less salt and those kind of things. But with the Asian culture, there can be some prepackaged things such as the noodles or some of the rice as well that can contain some of those starches and salts that make it a higher incidence just as far as from food. But it's more so tied to genetics. And with our African American culture, especially here in the South, and that just doesn't tie to our African American cultures. We love our good Southern soul food, which of course is filled with all those things that aren't great for us, but we love them. And then again, talking about genetic factors, which again goes with ethnicity as well. And then having a history of a mini stroke or a TIA. Those previous strokes or even having a heart attack before puts you at a much higher rate or incident of having a stroke again. Usually our major strokes that we have, that person has had a TIA or a mini stroke in the past before. Just because you have a mini stroke does not mean that you will have a major stroke later, but it does create a significantly higher incidence of the possibility of you having a stroke.
Did you have a mini stroke?
Absolutely, absolutely. My grandmother herself, we didn't find out for a couple of years that she was having little mini strokes in her sleep. And by the time she would wake up in the morning, she would be back to normal, be back to speaking fine, everything is fine. But it is absolutely possible to have mini strokes and not be aware of them. Usually what happens for those patients that have been having them, they'll have mini strokes, have a major stroke, which brings them into the hospital. And we'll do what we call an X-ray or a CT scan of the brain. And that's when we will see those little mini strokes that they've had in the past as well. Or we'll see those little plaque build up on the artery walls or some of the different arteries or some of the major arteries that now is causing little mini strokes. So remembering and referring back to that picture that I showed you guys before, what happens here with the plaque, as I said, is it kind of blocks it, but it doesn't fully block it. So a little bit at a time would be able to go through. That's what causes those mini strokes. Mini strokes are transient, which means they're temporary. Sometimes they can last for 15 minutes with symptoms, and sometimes they can last for hours with symptoms. It just depends on the blockage, how much of that artery is blocked and how long, and if they're able to dislodge it at all. But that's usually how those little mini strokes are happening, and how we can have an incidence of having those symptoms and not knowing that we had those symptoms, especially if they're happening in our sleep, or if they're happening in a time and they resolve really, really quickly. By the time you notice it and ask someone, hey, it's something a little different, it's probably resolved by then. Yes?
So, there was no other medical exam that showed TIA or brain.
But the brain scans. We have different scans that we can do of the brain, but those are the only ways that we will be able to see it. Just because we have to be able to have a visual of those arteries and that lead up to your brain, and that's how we will see it. So again, talking about risk factors. Now, these are the modifiable or the things that we can change. And I think we probably all, some of those can relate or at least expand on those. So things that you can change, hypertension. We can't change the fact if hypertension is something that's genetic or a part of our family, but we can change the control or have control over how well our blood pressure is being controlled. The number one past medical history that I see for our patients that come in with stroke, because I do have to review all of them, is high blood pressure. I would say probably 95% of them all have high blood pressure. And it can be different. Sometimes they're taking their medication and they're doing those things that they can to try to prevent. And sometimes they're not. We call them non-compliant. You may have heard that word before, non-compliant, where they're not really following their medication regimen as prescribed by the doctor. Diabetes is also another one. We can't change if we have a genetic predisposition to diabetes, but we can change and modify how well our blood sugars are being controlled. If you're on a medicine, as well as for hypertension, if you're on a medicine for diabetes or hypertension and you're having your blood sugar or your blood pressure checked and it's still above those ranges, go back to your primary doctor and have a conversation with them. A lot of patients will still be in those high ranges, but they think that they're on the correct dose because this is what the physician prescribed. When those medications can be modified and changed. There's not a one fix for all. Every dosage is not going to work for everyone. And there's usually a lot of room to kind of shift and change those doses. And we're just not aware of that. We think they give us this, we take it, and it all works. But there's still a part that we have to do on the side as well with monitoring and giving that feedback. Atrial fibrillation or AFib, which just means an irregular heart rate or heartbeat. Our heart usually pumps in love dub. AFib happens like this, where the heart is quivering and not able to adequately pump blood the way that it's supposed to. And when our heart isn't able to do that, what happens is the blood flows back into the heart. It gets thick because it sat too long, and it causes blood clots. And those blood clots are those things that are traveling through the body, causing stroke or could cause a heart attack. Other heart and blood vessel disease as well. We can't change if we have those things, but we can make sure that we're monitoring, taking care of ourselves, and getting the necessary care that we need yearly or semi-annually if the doctor needs to, and seeing our specialists such as a cardiologist. High cholesterol, and again, that goes back to medication and management and knowing our numbers as well. Smoking and smoking cessation, that's something that is modifiable for us. Substance abuse, as well as obesity, those are all risk factors that we can actively work to change and have some control over. So when looking at the signs and symptoms of stroke, what do I need to look out for? I think you guys got to see that poster over there on the side. And to know signs and of sudden signs of stroke. If you see someone experience any of those symptoms, the best thing that you can do is try to get them help as soon as possible. We say, and I had it at the beginning, time is brain. That's our slogan, because with every second, there's less interventions that we can do. We have numbers of things that we can administer to patients if they come in within a certain time frame. But once you hit over that time frame, those things aren't available anymore. So now we're just trying to do symptom management and monitoring. So time is brain. Time is brain. So it's the sudden uneven facial drooping. I think you guys have seen those classic pictures, and I have a picture on the next slide as well. But sudden facial unevenness or facial drooping. Usually very notable when someone is trying to speak or smile. We'll see that as a way to try to have someone to smile. Sudden limb weakness, whether it's their arms, not being able to support their arms, or their legs. That's usually a very quick indicator. Sudden speech difficulty, which again goes back with that facial drooping and just overall weakness. Sudden dizziness, trouble walking, or a loss of balance or coordination. Sudden trouble seeing in one or both eyes, which is fairly common. Not being able to see, having one eye that is blurry. In some of our more major strokes, patients will come in and one of the eyes will deviate or be over to the side, as we'll say. So they're not able to keep both eyes straight. And again, that comes with the weakness of the eye muscles and not being able to use those. Sudden severe headaches with no known cause. If I have a patient and I'm seeing them and they tell me they have the worst headache of their life, that's a medical emergency to me. The worst headache of your life is very specific. It's very specific language for someone to use, and it's usually an indicative or a sign of someone having a stroke. Again, sudden numbness of the face, arm, or leg, or sudden confusion or trouble understanding others. Usually what happens when a patient is having a stroke, they'll have something called aphasia or difficulty, which means difficulty speaking. They'll know something is wrong, but they can't verbalize to you what's wrong. Or they'll try to point at things, or they'll get frustrated because they can't talk to you or tell you what's going on. It kind of feels like for them a kind of brain scramble, where you're wanting to get these things out, but you just can't get it out. And we call that expressive aphasia. So again, now here's a visual that I want you guys to be able to see with the face, again with the drooping face. So what to do if you think you may be having a stroke or someone you know may be having a stroke. Again, time is of the essence, time is brain. And we're using that time to call 911. So you'll hear us talk a lot about Be Fast. You guys may have seen those signs out and about and just in the community. They have them posted everywhere because this is a standard wording and a standard acronym for our United States medical field in general. So Be Fast is a common term that we all use. B stands for balance or loss of balance, headache or dizziness. E stands for eyes, again, a sudden loss of vision in one or both of your eyes. F is for face, does the person's face look uneven or that facial drooping? A is for arm, which is that weakness. S is for speech, which is difficulty in speaking and having that aphasia. And again, T is for time to call 911. And again, just reiterating with eyes, going back to that vision. If a person has high blood pressure, one of the common signs of them knowing that their blood pressure is high is usually they'll get a blurred vision, which again is a sign, a symptom of needing to get more help or needing to be seen about that. Now, some lifestyle changes, which we're going to look at our handouts a little bit more and talk about some healthy diets, but some of those things that we can change, diet being the biggest one, of course. Adding in those healthy fats, those healthy grains that take longer for our bodies to break down, making sure that we're including our vegetables, our fruits, and all of those things that we need. Physical activity, getting out and walking. Physical activity doesn't necessarily have to be going to the gym, running on the treadmill. It can be something as simple as taking a walk around the campus or walk on the track. Just being more active in what you are doing. Obesity, and again, that ties back to diet as well as our exercise, our cholesterol levels. And remembering that cholesterol levels are things that aren't modifiable as if we have it, but we can control and be aware of what our numbers are and what levels to go talk with our doctors for. Diabetes, being aware of your blood sugars if you are diabetic, knowing your levels, knowing how much insulin you take if you have to take insulin or if you're on metformin, being aware of those numbers and having those conversations with your doctor. Hypertension, again, being aware of your blood pressure levels. I love to encourage people to be in charge of their own health. It's our own personal health, and the doctors can only do their part of it. The other half of that work is us taking care of ourselves as well and being in control of our overall health. Smoking cessation. If you do smoke, getting on a plan to stop smoking, whether it be the patches, the nicotine lozenges or the Nicorette gum, getting on a plan for smoking cessation. And then limiting alcohol use. We all, social drinking is completely okay. Red wine is actually good for the heart, which we know, but limiting that alcohol use and not overusing that, using that to socially drink responsibly is completely okay. But limiting that if you are having a heavier intake of alcohol. Now, I think we're gonna just go ahead and kind of look. I gave you guys some really great papers there. Some from the CDC, some from My Healthy Plate. So we're gonna look at the My Healthy Plate handout first, you guys. And in that Healthy Plate, it kind of gives you, again, a visual. And I think we probably all have seen this since childhood and growing up with those plates with the colors. Now, I think the amounts in each one of the little triangles have changed a little bit through the years as they learn more and decide what we need more of, but the standard is still there. So with this, we want to make sure that we're finding our healthy eating style. Everything you eat and drink over time, it matters, and it can help you now and in the future, creating those healthy lifestyles, those healthy eating styles to where it becomes a habit. So again, we're wanting you there to focus on whole fruits, varying your vegetables. If you have vegetables that you like, varying those, picking those in different ways or consuming them in different ways. Grains, we want to make half your grains whole grains. And again, this is me discussing those whole grains or grains that are harder for your body to break down. And we've all heard brown rice versus white rice. While they do hold the same common carbohydrate content, because that's usually what we know, or carbs break down into those sugars. But the difference in the brown rice is that it takes the body longer to break it down. What that means, it keeps you full longer and it lasts longer and has a better control of your blood sugar in your body versus intaking white rice, which can break down really quickly and causing your sugar levels to increase really quickly and drop really quickly. But those healthy grains, that again, just take a little longer to break down, like the wheat and those different kind of grains. Proteins, varying your protein routine. We have some great healthy fishes that have those omega-3 fatty acids, which we know are good for the eyes and for the brain. Lean meat, such as lean chicken, those kind of things. Those kind of things are really, really great. And then we can't forget dairy. We want to make sure that we're moving to low-fat or fat-free milk or yogurt. Those lower-fat milks and yogurts are going to be better for you because they're also helping to reduce your cholesterol levels as well. And then just out about, we want to limit the extras. Drink and eat beverages and food with less sodium, saturated fats, and added sugars. Being aware of what it is that you're putting into your body. And remember, everything in moderation. We don't want it to be an instance of where you're not getting anything that you enjoy. Absolutely, of course, because that's no fun. But we want to limit it. Everything in moderation is okay. It's all in moderation. And then when you look here on the back of that, it gives you a better breakdown of how many cups and how many ounces of things that you guys can consume. And you can definitely take that with you and able to look at that at your leisure. And then, of course, now we don't want to forget the water. Water is extremely important. Water, our body is consisted of mostly water, as well as our vessels need that water and that hydration to move that blood throughout them as well. Now, the next one is called Know the Facts About Stroke, and this one is from the CDC. And again, this is just a little handout that kind of summarizes everything that we've talked about today, with first going over what is a stroke, and then knowing if you are at risk of having a stroke. And then what do you do if you have a stroke or someone that you're with, you think they may be having a stroke. There's no such thing as a false alarm. We love false alarms. Those are happy times for us. So if you think someone may be having a stroke and then we determine in the emergency room that they may not, or in the hospital, that's completely okay. We love false alarms. We'll rather you come in, get evaluated, see what's going on, because if you're having some type of symptoms, even if it is not a stroke, it could be something else that we need to see. There are certain things that may present or may have people thinking that they may have a stroke, such as a seizure or other different things. Low blood sugar could present some symptoms as if you're having a stroke as well. So if there's something going on, it's always important to come in so that we can at least figure out what is going on if it's not a stroke. And then on the back of that form there, again, we do have some of those where the signs and symptoms, using the BFAST method and looking at the time and making sure that we're calling 911 as soon as possible. It also, down at the bottom, talks about how is a stroke diagnosed. It talks about those brain scans that we can do to see the different vessels in your body. There's entry-level ones, such as a CT scan that we would do, and there's more in-depth ones, such as an MRI, which shows us a little bit more and can show us over a longer span of time of what we're seeing. And then, of course, it talks about if it can be prevented. Now, remember in the beginning, we talked about 80% of strokes here in the U.S. are preventable. That is a huge number, and I want you guys to remember that. Because if we were working towards that and you're aware, we can work to prevent those strokes that would happen. And then just talking about different treatments for stroke as well. And then our last handout here, I just wanted to bring some information about high blood pressure and stroke. Again, because the majority of the patients that I see have a past medical history of high blood pressure or hypertension. So I wanted to make sure that you guys had some great information here on that. And it talks about what is high blood pressure. And again, those numbers have changed throughout the years. Right now, we're looking at 120/80 as our standard, and anything over that is pre-hypertensive and then moving into hypertension. A few years ago, when I first started nursing school, it was 140/90. So it's important for us to keep an eye on what are the new recommendations. And your doctor should be talking with you about that as well, on the difference in the recommendations for you and what's a good number for you. It also talks about how does high blood pressure increase your risk for stroke. And again, it's the #1 cause of a stroke and what we significantly see here at the VOU. And then it talks about those who are at higher risk for high blood pressure, which we talked about that a little bit with those diets, including lots of salt, age, as well as African Americans are being overweight or obese. And then on the back there, it does talk about some ways you could work to control your high blood pressure. And just as the same as with stroke, it's a lot about losing weight, healthy diets, your salt intake, especially because that directly has a significant impact on your blood pressure. Taking your medicines as prescribed. I cannot stress that enough, as prescribed. And if you're having issues where your blood pressure medicine may be making you feel dizzy or anything, that's also something concerning to talk with your doctor about. Again, there's lots of branches and different medications that you can be on. So a lot of that stuff is changeable. And it's just about communication with your primary doctor to get those things rectified. All right, you guys, and then I think that's about it. All right, do we have any questions? I hope that was a lot of information in a little time, but you guys need to keep those handouts. I also included some little easy magnets there that has some of those information. I love the magnets because they're, anytime I'm going into the refrigerator, it's kind of like a reminder, like, let's turn around and go back after we read that. But I added some magnets in there for you guys, as well as some little handout booklets that again goes through all of that information. And then you guys can read it at your leisure. Does anyone? Yes.
So I'm confused about the alcohol because recently they've been saying that women at any age should be drinking alcohol. Let's say it should be in cancer. They don't say much about anything. I mean, so I'm confused. You said red wine was good for the heart.
Yes.
And I don't believe anything.
And I've seen that as well. And a lot of times when I'm reading, you're always aware of the source, of where it's coming from, and what's their perspective on what it is that they're writing. But I have seen those things as well. Of course, there's going to be, I think the messaging a lot of the time is not over consuming, but I have seen those same reports of not consuming at all and the adverse effects of consuming alcohol at all. I think a lot of the issues come with the processing or what they're adding into it, those additives that they're adding into it, or the way that they're processing it and the things, the chemicals that they're adding to it in that way. From what I've seen and from what we've discussed. I've discussed this before with our medical director of just making sure that the information and communication that we're giving to the patients are what we're still seeing in research as well. But I have seen those conflicting articles and conflicting information. As of right now, we're still just telling everyone to limit their alcohol consumption, not to fully, completely not drink. Yeah, but I have seen those same things as well. But I think more of that is tied to what they're adding to those, I say hard liquors when I'm talking about spirits, such as gin or tequila, what they're adding to those things. Even the barrels that they may be distilling or filtering it in have chemicals in it that are coming over into the alcohol. I usually hear those things, like I said, more about hard alcohol versus the red wine in reference to health. Yes.
My question is on TIA, which is transient ischemic attack.
Yes.
Is it as a transient, it could happen again? What is the major cause? Is the heart is the problem, or the blood vessels are the problem, or the brain tissue is the problem? What can you prioritize these?
So usually, yeah, well, and it can be. It just depends. Some patients can have what we call the trifecta, where they have heart disease, they have other vessel disease as well. All these things, these factors that are leading up to that. But with our TIAs or our transient ischemic attacks, a person can have a mini stroke now, and literally in 12 hours they have another one. And there's not that there's something wrong with the tissue, there's a blockage. And if they're unable to identify exactly where that blockage is and clear it safely, because sometimes we can't safely clear blockages, but if they're unable to or are unable to identify, then that risk is still there. So it's like having a water hose that, you can bend it and it kind of decreases the amount of water that can come through it. It's that same thought and concept. As you open it up and release it, more water can flow through. But if you keep it there in that same spot, only a little bit of water will be able to come through. So it's that same thought.
And the very first thing you will see the slide of the brain to be the outer artery, to be a left side or right
On the right side, yes.
If they get diagonal, they will not be 50% of the artery or one or the other artery. That enough knowledge to lead to
it just depends, and it depends on the person. Sometimes the symptoms will be so
60, 70 years.
That's if something is 60 to 70% occluded, I'm worried. That's a heavy or a lot of occlusion. Usually with our TIAs, we're seeing a much less amount of occlusion than that. When we start talking about our arteries being 70% occluded, I actually have a patient now who has a 70% right MCA or one of those right major arteries occlusion. But because the patient is 97, we're unable to do any intervention. So we just kind of changed out some medicines to make the blood thinner. But usually with our TIAs, we're seeing less occlusion than that. When you start going up into anything after 60%, you're usually seeing your major strokes from that.
If you have a lucky rate, let's say around 50 or 60%, every warrant has ATP operation of the blood artery really
You're saying that if it's 50 or 60%, should you be doing some kind of surgical intervention?
If this person is around 60 or 70 years old,
it just depends. Everyone is different, so I don't want to say yes by absolutely they should, because everyone is different. There's other things, there's different ways to remove clots. I'll say that without getting too in-depth in it, but there's mechanical versus different surgical ways. There's different ways to remove it. It all depends on the patient. We're always weighing risk versus benefits. So with going inside of anyone with any kind of little tools into a vessel, there's a very high risk of rupturing the vessel and now having the patient to be bleeding on the table. And again, if we're talking about those major arteries, if you accidentally puncture one of those, you have maybe 5 minutes before that patient is gone. So it just kind of depends. Again, risk versus benefits. They'll also do things like placing stents. If you've heard of a stent is a little metal device. It kind of looks like a metal cheese grater, if you think of it that way, a little piece, and they'll put it in there if they're unable to do a surgical removal. And the whole point of that is that we can't remove the clot, it's here, or we can't remove the occlusion. But if it starts to travel, let's protect the major parts of the body, such as the heart and the brain. So they'll put a stent. Just say if your clot is here, they can put a stent that's up closer to where the entrance will be to that brain, so that if that clot did move, it gets stuck in that grater and it's stuck there. So it just depends on the person and risk versus benefits of if there's a need for surgical intervention.
And my next question is,
We'll get right to you.
what is called turbulence? Between one of the clotted artery must be accepted to see that the cause was not a hemorrhage or clot, turbulence.
You said what was the cause and what? I'm sorry.
Turbulence.
The turbulence?
Yeah. Turbulence. That's the terminology used. The blood was going through a turbulence, so that is hemorrhage.
Oh, okay. Instead of the hemorrhage, you're saying that they have a clot? I'm sorry, I just want to make sure I understand it correctly. The question right.
The terminology is turbulence, TURBULENCE.
Turbulence?
Yeah. You have any information on that?
No, I'm not sure. That's something I can get back with you. I don't want to tell you anything that's completely wrong. It may be a different way or a different term that I may have learned it. But that's definitely something I can look into and provide information back with that. So blood clots can have several different presentations, or you cannot know at all. If you have a clot in an area such as your leg, we'll call them, you hear say a DVT or deep vein thrombosis. You will usually have pain at that site, you will have swelling at that site, and it'll be very hot. Our patients that have a DVT that stay in their thigh, if I touch it, it feels very hot according to the rest of the leg. And they'll have pain there and it'll be swollen as well because that clot is there. But there are a lot of instances where you wouldn't know. Patients can have a PE or a pulmonary embolism or a blood clot in their lungs or close to their lungs, and you may not have any symptoms. You could be short of breath, which is a sign of it, but a lot of our patients don't know that they have one at all. It could. Absolutely. Yeah, so a lot of the doctors will, especially if you had a mini stroke before a TIA or had a previous stroke in the past, they'll recommend you taking what we call a baby aspirin, which is just a little 81 milligram aspirin that we can get over the counter. And for a lot of our patients, if you have heart disease or anything, they'll recommend that as prophylactic or something as kind of like trying to prevent. Now, aspirin isn't one of our strongest. So if you do already have a clot, it's not the best defense against it. Aspirin is used more of a preventative measure. That we've cleared it all out, we've given you higher dosage things in the hospital, we've dissolved the clot, and then we'll send you home on aspirin, or aspirin taken at home to prevent. If you already have heart or artery disease, they'll give you aspirin. But theoretically, yes, that if you do have a clot, the aspirin will thin out your blood so that maybe a little bit of the clot will dissolve, but not much, not enough that will be significant or would push you, make the risk a lot lower of that clot moving or dislodging. Usually, I've never seen someone have 2 DVTs at one time. It's possible. I have seen patients have 1 DVT, a PE, and clots in other little places, or little clots in their lungs because they either have a clotting disorder, or for some of our younger patients, it's usually associated with birth control or those kind of things. We all have heard that even with our COVID vaccines, there may be something there as well. So there's just different things that could lead up to that. But usually I've never seen 2 DVTs in one leg, in both legs. Pain in that leg. And compression socks are really, really good as well. We encourage people to wear those because it keeps that blood flow going. It kind of acts like mechanically walking. It keeps it really tight, so it keeps that blood going. What usually happens is, think of how we fly on a plane. If you have a really, really long flight, let's say 12 hours, they recommend you get up and walk up and down the aisle every 2 to 3 hours. That's to keep the blood flowing in your body. As I discussed before, when we were talking about the heart and AFib, and remembering with AFib, it doesn't fully squeeze, so the blood doesn't get throughout your body. It comes back in, it pulls. Blood is very viscous. If it sits, it's gonna pull and it's gonna get thick, and that's what's forming those clots. So wearing compression stockings are great because it keeps that blood moving and it keeps some kind of compression. And getting up just to walk a few steps, walk back and forth. If you're sitting for long periods of time, is really good as well. That's why those big blood clots are likely to form in those legs, because you have those major arteries there, and we're sitting with our legs down with our blood pooling. We're just kind of being at a standstill. We're not moving. But I would definitely talk with my primary care physician if that's something that you are concerned about, just so that that's something that you can have looked at and maybe have seen. There's different tests that they can look to see if you have a blood clot. This is for testing to see? Yes, there's absolutely testing that they can do to see if you have a blood clot. There's blood that they can draw to see if certain levels are higher than others. There's also ultrasound scans that they can do as well to visualize those vessels to see if there's a clot there. Yeah, and that's a lot of times where patients really are in that kind of middle ground of they're in between care. I've changed my primary doctor several times, not wanting to in the last few years, just because the doctors are moving and shifting around a lot, and it can get frustrating. I've had patients that are frustrated because they go to their primary that they've had, and now they have someone new, and now you're trying to explain your whole life story all over again to someone new, which is very frustrating, and trying to let them know the things that are wrong with you when you had that relationship with your previous doctor. So I definitely would encourage looking into a PCP around this area so that you can get things like that looked at, because it may be something more. You don't want to have those blood clots really. Because we can't control, once they move, we can't control where they go. Yes.
So how do you diagnose the TIA? No.
How would you diagnose it?
Yeah.
So if we can still see it, then they'll go in and they may be able to do something about if there's still a significant occlusion, again, depending on the size, what's going on, risk versus benefits, age.
Looks like your grandmother who's having TIA.
Mm-hmm. So they can see old little, they'll call them infarcts when they talk to you. Yes, infarcts.
Okay.
When they did her scan, she's epileptic. So she annually has scans done. When they did her scan, they could see little white matter spots, which is usually little tissue damage. And that's how they were able to say she's been having little mini strokes. They couldn't see the occlusions in vessels, but they can see in her brain tissue that something had previously happened. Yeah. That was a good question. Yeah, with the TIAs. Yeah, and usually for our TIAs, they'll come into the emergency room and we're sending them back home because, again, their symptoms have resolved. They're not in immediate danger or an immediate threat right now. So we'll usually end up. Yeah. So if someone comes in and has a mini stroke, or we suspect they've had a mini stroke, a lot of it is based off of who found them, what were the symptoms they saw. Some things, again, are very classic, and we'll send them out on prophylactic things. Again, the baby aspirin, a cholesterol medicine if they weren't already on a cholesterol medicine, to try to inhibit those things from happening again or having a major stroke later. But yeah, usually we don't know the TIAs unless they're coming in until they have that major stroke. And we do that scan and we see those little spots on their brain from where tissue has died from lack of oxygen. Yeah. Right. I'm not sure if anyone online had any questions.
Okay. Online questions.
Did anyone have any questions in the chat?
There should be in the, is it on there?
Let's see.
That's what you should.
I can
Let's see.
stop. No, I don't see any questions in the chat.
Okay, is Valerie paying attention? Hold on.
Yes, Valerie was on earlier.
Okay, let me see.
Well, I hope this information was really useful and helpful for you guys. I would love to be able to come back, talk with you guys more. If you think of other questions, please don't hesitate to let them know so that they can get those to me, and I will personally make sure I follow through. I'm going to follow through with that turbulence. Now I really want to know. I like to know your things, so I'm going to follow through on that and get that information back to you.
And the other thing, remember we're going to talk about the mask. Did you reinforce that?
Yes, remembering COVID. Prior to this role, which I just came into this summer, I actually was a part of our Emory main campus infection prevention team. I was one of the first people to have a patient with COVID. I developed a lot of standards and protocols around COVID. I will say that our COVID numbers in Georgia are rising again. We all know that it is flu and cold season, but it is also COVID season, which is year round. But our numbers are starting to rise again, so we want to make sure that we're wearing our masks, that we're getting our vaccines, that we're sanitizing, using good hand washing technique, social distancing, all of those great things. If you're having symptoms, identifying those and staying to yourself so that we're not possibly infecting anyone else. But I did just want to say that previously working on that team, I follow that a lot. I still follow a lot of the research, but those numbers are rising, as are our flu numbers. Everyone in my house has had the flu so far. So it's really bad out here. So you guys, please make sure that you're wearing your mask and stay safe.
Thank you so much.